Welcome to the third part of my presentation. In the first two parts, the focus has been on ocular proprioception. This time, the focus will be on visuospatial attention. Attention implies withdrawal from some things in order to deal effectively with others. When psychologists speak about attention, they often talk about information overload, perceptual bottlenecks, and the need to select the most important information. The sensory organs relay a wealth of information to the brain. This is much more than what our brain can process. For this reason, only a fraction of the incoming sensory input can be processed further towards perception and action. It has been calculated that we are aware of about 1% of the visual input, so 99% of the information is lost. I added on this slide a link to the theoretical discussion and also a very nice hands-on practical demonstration where you can try for yourself to see how much information you are aware of and how much you are not aware of. To illustrate the attentional priority map, I put on this slide a picture. This is my favorite picture taken during the COVID lockdown. I had to travel for an essential reason and stopped at a petrol station just off the motorway to put petrol in my car. When I wanted to leave, I realized that a flock of geese has been sitting comfy in the exit way. So the attentional priority map would only have a summary of the visual scene with the most important information highlighted, in this case, the flock of geese. Can I use this information to choose a way to drive my car? Yes, but only if my eyes do not move from the moment I perceive the geese and until I have driven past them. This is unlikely. Our eyes are in continuous motion, and not only when we drive, because the driving instructor has told us to move our eyes from the mirrors to the instruments to what is outside, but also because physiologically the eyes are continuously in motion. If you take an eye trace from an eye tracker, you will see that the eyes are never still. You will never see a flat line. So, the fact that the attentional priority map is in retinotopic coordinates is a problem. And we know that the spatial attention map is in retinotopic coordinates, which means that locations are coded relative to the center of the retina. Because of the studies highlighted here and as well as others, where a cue was presented, the participant was asked to move their eyes, and then the locus of attention was probed. And it was found out that the locus of attention lingered in retinotopic coordinates, so it was at the retinotopic location of the cue and not at the actual physical location of the cue after an eye movement. And why is this a problem? This is because, as I said before, our eyes move relative to the head. And it's difficult to keep track on the physical location of an important object. And it's also difficult to align a visual object with a sound or a touch on the hand, because sounds are coded relative to the head midline. A touch on the hand would be coded relative to the body midline. This is how our sensory receptors code sensory information, and because they move relative to each other, it is important to incorporate information about the rotation of the eyes in the orbits, information about the rotation of the head on the trunk. There are two ways in which this information is incorporated into the attention maps. One is by remapping, which means that the neurons update their receptive field, so they update what information they code just before an eye movement, and so from across eye movements, the physical position, the actual position of the cue is preserved. Or gain field neurons, which have both a retinotopic receptive field and respond to the direction of gaze. So they code both the retinal position and also the rotation of the eyes in the orbits. Now, what I want you to notice is that both these ways of transforming the coordinates of the retinotopic map, of the attentional priority map in retinotopic coordinates to body-centered or head-centered coordinates involve the need of extraretinal information which conveys the rotation of the eyes in the orbits. Until relatively recently, it has been thought that this update takes place before the eyes actually have moved. So it's predictive, and because of that, it was unlikely that ocular proprioception had any contribution, and it was thought that the corollary discharge is the gaze direction signal that is important for updating the attentional priority map. However, more recently, it was found that the attention locus lingers in retinotopic coordinates for up to 150-200 milliseconds after an eye movement. And this is, in theory, enough for the ocular proprioceptive signal to reach the cerebral cortex. Now, is this evidence that ocular proprioception plays a role? I don't think so. It could be that this delay is caused by the actual processes that are required for the update, and it does not necessarily reflect the delay of proprioception in ascending fibers. And therefore, it seemed relevant to ask whether ocular proprioception contributes to coding the locus of attention, and use the methods that I was presenting in the previous part of my talk to find out. So the task for this experiment is like this. We had healthy volunteers coming in the lab. They sat in complete darkness and they fixated on a cross. This cross was located to the left or to the right of the body midline, and we did so because we knew that with transcranial magnetic stimulation, their gaze would be underestimated, so we had an idea about the direction in which the ocular proprioceptive signal will be biased. So for instance, when the gaze was to the left, transcranial magnetic stimulation over the somatosensory area would cause a shift in perceived gaze towards the right, as you see in the figure. We provided a cue for the most likely location where the visual target would appear, and this cue was the position of their left hand. The experiment took place in darkness, so they could not see the location of their hand. And then we presented visual targets like the letter A, for instance, you see here, at various locations around the location of the hand. We asked them to carry out a simple visual discrimination task to tell us whether the letter they saw was A or H, and represented the letter A half of the time, the letter H the other half of the time. We measured the accuracy and the reaction time for visual detection, for visual discrimination. And we hypothesized that after manipulating the ocular proprioceptive input, we would see a shift in the locus of attention in the direction of the shift in the gaze, meaning that instead of attending at the exact location of the cue, they would attend more towards the right in this case. And that would be apparent by a change in the accuracy or the reaction time. This was the setup for transcranial magnetic stimulation, which I have already explained. This is an illustration of the hypothesis. So on the x-axis, you see the position of the target. And on the y-axis, you see a difference between the reaction time in the presence of the cue and the reaction time in the absence of the cue. So if the cue successfully directs attention to its location, then the reaction time in the presence of the cue should be lower than the reaction time in the absence of the cue. Before TMS in black, one would expect to see this to happen at the exact location of the cue. So if the cue is presented at minus 30 degrees, then the maximum benefit of the cue, the lowest value of this difference in reaction time would be at the exact location of the cue. This is where attention was directed. After TMS, the gaze direction would shift to the right, and so the locus of attention was expected to shift to the right as well, causing this largest difference between the condition with an attention cue and a condition without an attention cue to be at the location more towards the right. So we predicted that the benefit in visual perception would shift towards the right. I forgot to mention that this task is very easy and the accuracy is close to 100% for all participants, and therefore it makes sense to use reaction time. And now let's look at the statistics. So we tested the participants in leftward gaze and in rightward gaze, and we used the somatosensory cortex active side and a control side which was now in the posterior parietal cortex. We chose this area because we know that the posterior parietal cortex plays a role in spatial attention, and we wanted to control for current spread from the location of the ocular proprioceptive area further posterior towards the parietal cortex, and make sure that the effects we are seeing come from the somatosensory cortex and not from the parietal cortex. So in leftward gaze, as I was telling you, repetitive transcranial magnetic stimulation shifts the direction of the gaze rightwards and also causes a shift in the locus of attention towards the right. So shifts towards the left are below, shifts towards the right are above the zero line. So in leftward gaze, we saw a shift rightwards in the locus of attention for all tested locations. And this was the other way around in rightward gaze when the shift was below the line towards the left. So, transcranial magnetic stimulation caused a shift in the locus of attention that was gaze dependent. This was specific for the attention, for the stimulation area in the somatosensory cortex, and did not occur for the stimulation area in the posterior parietal cortex. Could this have been caused by a mislocalization of the hand relative to the body? To find out, we used a second task in which we asked the participants to point to this location rather than to attend to this location. And we looked at the accuracy of their pointing movement. Unlike spatial attention, during this task, which was again performed in complete darkness, the participants were accurate. There was no change in the accuracy of pointing for any direction of gaze and for any location of the target. So, the conclusion of this transcranial magnetic stimulation study is that ocular proprioception plays a role in the allocation of attention in the visual space. Because this was a transcranial magnetic stimulation study, we were still worried that the current might have spread, even though we controlled using the posterior parietal cortex control site. And so, two replications of this study using different methods. A method was to test the allocation of attention in the patient RW, whom I described in part 2 of my talk. This patient has a focal lesion in the somatosensory cortex. And a second replication used a scleral lens. This is the method proposed by Gauthier, where the where the extraocular muscles are stretched, passively stretched, and that study as well identified a change in the allocation of attention. Furthermore, we looked at brain areas where the application of transcranial magnetic stimulation in the somatosensory cortex was changing. In this study, we scanned the participants before and after transcranial magnetic stimulation over the somatosensory cortex. There were 4 behavioral conditions, as you can see here, the gaze either to the left or to the right, and the target either to the left or to the right. And then we looked at brain areas where the response to a right target changed depending on the direction of gaze. And this was identified in the left visual cortex. Similarly, for the left target, we identified the brain areas that responded to the left target depending on the direction of gaze, and those were identified in the right visual cortex. As you can see in these figures, the change is significant when repetitive transcranial magnetic stimulation is applied in the somatosensory cortex and does not occur for a control area in the motor cortex. And that's the same for both the right target and the left target. So the conclusion from this series of experiments is that ocular proprioception contributes to coding the locus of attention in the visual space. In my last few slides, I'd like to talk about an attention disorder called spatial neglect, in which patients after a stroke in one brain hemisphere fail to attend to one half of the visual space. So often the lesion is in the right brain hemisphere, causing neglect of the left visual space. And you see on this slide one of the tests used to diagnose this disorder. The patients are asked to copy a clock face, and this patient has placed all the numbers on the right side. There are two hypotheses, or there are a number of hypotheses about the disease mechanisms in spatial neglect, and I've highlighted two of them here. One is that the left half of the attention map is gone because the neurons that host it have been destroyed by the lesion. Now, one of the main objections against this hypothesis is that the brain areas that implement the attentional priority map are in the superior parietal cortex, superior frontal lobe, and those areas are rarely lesioned in patients with spatial neglect. There are, of course, some ways of explaining this, but it is the main objection against this hypothesis. And an alternative hypothesis based on the research that I've just presented is that the attentional priority map is intact, but the peaks, the locus of attention on the map, does not accurately reflect the location of the attention-worthy objects. Now, these two hypotheses give different predictions about what would happen in the healthy visual space. Because if the left half of the attention map is gone and the right half of the attention map is intact, then attention should be normal in the right hemisphere, whereas whether the entire priority map is affected because the peaks do not reflect the location of the actual attention-worthy objects, then we should see that the attention map in the right visual space is abnormal. Let me illustrate this hypothesis with a figure. So we know that the attentional priority map codes location relative to the center of the retina. And if the attentional priority map is in red, like here in a healthy person, if the brain has an inaccurate sense of the direction of gaze and thinks that the eyes are oriented towards the right, then the attention peaks would be shifted towards the right and attention will be allocated predominantly towards the right, causing spatial neglect. To test this hypothesis, we included 4 patients with spatial neglect, 10 patients with a lesion in the right hemisphere but no spatial neglect, and 10 healthy elderly controls. The task was very similar with the task I've just presented for the TMS experiment in healthy people. The experiment took place in complete darkness. The participant fixated on a cross that was located to the right side of the body, and they had an attention cue, which was the location of their right index finger. They had to tell whether they saw the letter A or the letter H, and we recorded accuracy, which in this experiment is normally very high. The patients were no exception, and also the reaction type for making this judgment. So where do they allocate attention? We presented the letter A at various locations around the location of the cue, around the location of the hand. And here is an illustration of the hypothesis. So we hypothesized that in patients with spatial neglect with a cue at 18 degrees, the locus of attention would be shifted to the right. Whereas in the controls, we would see no shift in the locus of attention. So the maximum benefit for the reaction time in the presence of the cue would be at the exact location of the cue. And as you can see here, for 3 different positions of the hand, 3 different positions of the cue, we saw that the cueing error was towards the right, so they paid attention to a location that was to the right of the cue. Like for transcranial magnetic stimulation, the effects seem to be specific for spatial attention because reaching to visual targets without visual feedback is not affected. So patients with spatial neglect mislocate attention-worthy objects towards the right, indicating that their gaze input for the spatial attention is shifted rightwards. Of course, this is a co-occurrence, so this shift of the gaze rightward co-occurs with spatial neglect. We have not demonstrated causality, but we have provided evidence that the gaze is shifted in the patients with spatial neglect so that future research can investigate this causal connection specifically. Could spatial neglect be a purely ocular proprioceptive disorder? I don't think so. And I don't think so because we have patients, because I have worked with a patient with a lesion in the somatosensory cortex that affects the ocular proprioceptive area. Although that patient had a change in the allocation of attention in visual space, that change was not spatial neglect. Also, in patients with spatial neglect, when the lesion extends to the somatosensory cortex, this is associated with a less severe neglect. So, what is the hypothesis for future research? The lesion in spatial neglect may disconnect the attentional priority map in one hemisphere from some of its gaze input, and it could be ocular proprioception, but also corollary discharge, neck proprioception, or vestibular input. Any of these signals, when disconnected, could cause a misperception of the gaze towards the normal hemispace. And the proposal is that interventions such as somatosensory cortex repetitive transcranial magnetic stimulation could correct the gaze, and if the gaze is causal for the disorder of attention, then S1I RTMS could alleviate spatial neglect. Before I conclude, I'd like to tell you that this is work done over more than 10 years in Denmark, Germany, and the UK. During this time, I've had a great privilege to work with wonderful mentors, colleagues, and students. I'd like to take this opportunity to thank them all, as well as to those who funded this research. And of course, thank you very much for listening to my talk.